Hello friends, I hope you all are doing great. Now I am starting a video series based on MPN, which is also known as myeloproliferative neoplasm. Here's the classification which came in 2016, which includes the CML, which is BCR-ABL positive, CNL, which is chronic neutrophilic leukemia, polycythemia vera, primary myelofibrosis, essential thrombocythemia, chronic eosinophilic leukemia, NOS, MPN unclassifiable, and mastocytosis. Now, the hematopoietic stem cell has two types of morphologies. One is the BCR-ABL positive MPN and another is the BCR-ABL1 negative MPNs. Positive is the CML and the negative includes the polycythemia vera, essential thrombocythemia, and the primary myelofibrosis, which have the mutations like JAK2, CALR, MPL. These three are the driver mutation for the BCR-ABL negative MPNs. Now, first, according to the FAB classification, there is three categories. One is the chronic granulocytic leukemia, atypical chronic myeloid leukemia, and chronic myelomonocytic leukemia. First, the chronic granulocytic and atypical CML is differentiated based on the blasts. So blast is if more than 2%, it is classified under the atypical CML, while the less than 2% are classified under the CGL or either CMML. Now, to differentiate between the CGL and CMML, we have to look for the monocyte count. The monocyte count is usually less than 3% in chronic granulocytic, while more than 10% in CMML. And the other is this, we all know the basophils are the more than or equal to 2% in chronic granulocytic leukemia, while less than 2% in other two types. Now, the hallmark feature of CML we all have to remember is Philadelphia chromosome translocation 922, and it makes a BCR-ABL fusion gene, which is of different types of molecular weights like 190 kilodalton, then the 210 and 230. Yes, this is based on the response to tyrosine kinase inhibitor drugs. As we all know, the pathogenesis is the tyrosine kinase overactivation. So, as this is the molecular weight is less, it seen in ALL, while 210 kilodalton is seen in CML and 230 is seen in CML with megakaryocytosis or neutrophilic. And here's the significance is that this one, the BCR fusion gene, is having good prognosis for CML, while bad prognosis for ALL. We will discuss about the CML. This includes the three phases. One is the chronic phase, then the accelerated phase, and then the blastic phase. 80% patients came into the chronic phase, 10% are in accelerated, and 10% are in blastic phase. The common age group is around 40 to 50 years, which I already discussed in my video of leukemia approach. Now, the common clinical features that we have to ask for if we are suspecting CML are the hypersplenomegaly. This is because of the extramedullary hematopoiesis that mainly occurs in spleen. Then the lymphadenopathy, weight loss, and fever. These are the common complaints. Now, first start with the chronic phase. In chronic phase, to diagnose the chronic phase, we have to look for the peripheral smear and the bone marrow examination. In peripheral smear, starting with WBC series, as it shows the marked leukocytosis with basophilia. Then the blast should be less than 3%. There will be the myelocytic bulge. Around 20 to 40% cells are of myelocytic or premature myeloid cells. Now go on the RBC series. The normochromic RBC is seen mainly, and 1 to 10 RBC can be seen. Platelet count is increased with increased MPV, and the NAP score is decreased, which is around 0 to 20. Now, for to look into the bone marrow is the first the myeloid series. as we all know, the myelocytic bulk, the myelopoiesis is increased, which is markedly increased. So the ME ratio is also increased, ranging from 15 raised to 1 to 49 raised to 1. Megakaryopoiesis, there is dwarf megakaryocytes seen on bone marrow examination, and they also seen in increased in number. Then the erythropoiesis is also increased, but it is less than compared to myelocytes, so the ME ratio will remain increased. Other cells findings which are seen in bone marrow are the pseudogranulars, pseudo-Gaucher cells, and the C blue histiocytes. Here, now see some images. This picture is showing the myelocytic bulge, and the arrow are showing the myelocytes. And in this figure, there is the basophils are seen, which are smaller than the neutrophil, and nucleus is covered by basophilic granules. Now, in this picture of chronic phase, we see the giant platelets and the few giant agranular platelets also seen. Now, in chronic phase, in bone marrow examination, as I discussed, we saw the hypercellular marrow. There is a cellularity very less or absent of fat spaces in this image. Then the in B, many megakaryocytes are seen. Then the type of megakaryocyte are, as I have mentioned, the dwarf megakaryocyte is seen. Then the blast is very few, which is less than 5%, and the image is showing the myeloproliferation with erythroid and eosinophilic precursors. Now, the other two entries as I would discuss is this is the pseudo-Gaucher cell, which is also seen in Gaucher's disease, so it's named as pseudo-Gaucher cell. And this is the C blue histiocyte with bluish granules. Now, the criteria for accelerated phase, which is also came into 2016. Now, the accelerated phase criteria is mainly based on the response to tyrosine kinase inhibitors. So, we have to remember one sentence, which is the unresponsive to therapy for all the criteria. So, this sentence is common for all, so I am not repeating. With unresponsive to therapy, there is persisting increasing of WBC count more than 1 lakh, increase in splenomegaly or spleen size, thrombocytosis which is more than 10 lakh, or thrombocytopenia less than 1 lakh, more 20% or more basophils, and 10 to 19% blast. The basophils is in peripheral blood, while blast can be either in peripheral blood or bone marrow. These all are unresponsive to therapy. The provisional response to TKI criteria is also there. According to this criteria, we can decide whether the patient is in accelerated phase or not. So, accelerated phase, here is the one example. The aspirated marrow seen is the blasts are seen in this image. Then they are around 17%, as our criteria is 10 to 19%. Then there is a marked increase in blast, but they are the round oval vesicular nuclei with prominent nucleoli, which is the features of myeloid blast, and there also they are increased in marrow. Now, the WHO criteria for the next stage is our blastic phase. As I mentioned, the blast should be more than 20% in PS or bone marrow to diagnose it as a blastic phase. There may be extramedullary blast proliferation also seen, which can be seen in skin, lymph nodes, spleen, bone marrow, or CNS. The large foci of blast in bone marrow biopsy or entire intertubercular region, even if the biopsy shows. Now, if we suspecting the blast, we have to confirm it by the IHC marker like CD34 and TDT that they are the blast. These are some images of blastic phase. As we all know, the prominent nucleoli are seen. The blasts are seen in this image. Then the megakaryocyte also seen. Megakaryocyte type of the blastic phase is seen in this image, and the MPO stain is also done, which is the 70% blast cells which are the MPO negative, while the some MPO positive are suggesting the lymphoid blastic phase. As I have taken all my images for the Tejinder Singh. Thank you.